A patient population carries all possible physiological states and their probabilities. When a clinical state is absorbing, entering it is permanent. The patient can never return to any prior clinical state. This is not a boundary condition or an approximation. Irreversibility is built into the transition structure of the clinical process. Terminal organ failure is the canonical absorbing clinical state. Understanding this is foundational to interpreting survivor statistics. The clinical absorption time is the first moment the patient enters the irreversible state. Before that moment, the patient remains in active clinical states. After that moment, nothing changes in the physiological trajectory. This creates a clean partition at every time point: patients who have been absorbed and patients who have not yet. Survival means the patient is still in the second group. Conditioning on patient survival creates a new reference population. This population assigns 0 probability to absorbed patient trajectories. All probability mass is redistributed among the surviving patients. As time progresses, the survival probability falls. The denominator shrinks. Probability mass concentrates on fewer and fewer patients. This is a change of the patient population being studied, not a correction of a clinical measurement error. When the absorbing state represents clinical ruin, the conditional outcome is always above the unconditional one. Absorbed patients pull the unconditional population average downward. Conditioning removes those patients from the analysis entirely. Only the better functioning survivors contribute to the conditional average. The total expectation law makes this precise. The unconditional mean equals the conditional mean times the survival probability. This inequality is structural, not a statistical approximation. Observing the long-run clinical outcome after conditioning on survival gives a different result than conditioning on survival after observing the long-run outcome. This is not a coincidence. The conditioning event itself changes as time advances. At each time point, you are conditioning on a different surviving patient subpopulation. Behavior over long follow-up cannot be read from short-term survivor statistics. These two operations genuinely do not commute in clinical populations. In a patient cohort with certain eventual deterioration, the conditional outcome among survivors may rise toward better clinical states. This apparent improvement is pure selection. Only the most robust patients remain. Conditioning on patient survival describes the surviving subpopulation only. It does not mean the underlying disease process has improved. Conditional outcome can grow even as fewer patients survive. That inequality is about the selected subset, not the underlying patient population. Survivor statistics and population dynamics require separate clinical frameworks.